Hello, and welcome to Empower Her, a webinar on Black women and menopause. My name is Dr. Itunu Johnson-Sogbetun, also known as Dr. Show, and I will be facilitating this talk today. So a bit about me. I'm a UK-based GP with a special interest in women's health and the menopause. And it's very important to me that things about menopause are shared within the Black community because there's so much misinformation and so much lack of understanding, and that has caused a lot of confusion. So I'm here today to really clarify some of the questions that people might have about the menopause, but also about the treatments of the menopause and the other things that are complications that surround the issue of menopause. So I'm really here to spread news and light and information, accurate information about the menopause. Now, we're going to just start. And I just want you to really introspect on these two questions. And if you have, a notepad or notes on your iPhone, or even if it's a sheet of paper, just pen some very brief thoughts about what you know about the menopause, what words come to your mind when you think about menopause, but also what questions have you always had about the menopause. And I'm just going to give you a few seconds to just do that whilst we also wait for more people to join. So if you just have a little think about what you know about the menopause, what are the words that come to your mind when you hear the word menopause, and what are the questions that you've always had about the menopause, because we're going to have a time after this talk to really get questions from the audience that people might have, and really trying to understand what myths or what concerns people may have about the menopause and the treatment of the menopause. So I'll just give a moment for that to happen. So someone's written, well, hi, Auntie Mobs. Auntie Mobola has written hormonal changes in women, which may include symptoms like hot flushes. Very good thought. Okay, so we're just going to dive in now and start talking about the basics. Right, so what is menopause? So it's the natural cessation, that means the natural time of stopping of a woman's menstrual periods for at least 12 consecutive months. And that's really important because perimenopause is the transitional phase from your normal regular monthly periods to that point when you haven't had a period for 12 months. So perimenopause, some people might stop bleeding for about 2 to 3 months and then start again. That's perimenopause. And it's that transitional phase. But it's really important to understand that women start getting symptoms of the perimenopause of menopause in the perimenopause because of the hormonal changes, primarily the estrogen deficiency. And as the estrogen drops, and in the perimenopause, it does this crazy thing when it goes up and down and up and down. So the symptoms can be more marked in perimenopause because of that erratic change of the hormone, but also because of the decline in the hormones. So in perimenopause, we often see irregular periods, and some people might experience lighter, but some might also experience heavier periods, and various other symptoms which we'll talk about. Now, menopause is a universal biological event for all women, and it occurs in all cultures and societies worldwide, although the timing and experience may vary. And that's partly what we're going to be talking about today. What is the difference? What are the things that mark out menopause in Black women as a difference? Now, this is what we're going to be talking about. What is distinctive about menopause in Black women? So we know that Black women have an earlier menopause, so an average age of 49, which in comparison to white women is an average age of 51. They also experience longer menopausal symptoms. So for Black women, it can be as long as 10 years where they're suffering from the symptoms, whereas it's shorter in white women. But this also quite concerning that Black women are 3 times more likely to have premature menopause, and that is defined as menopause before the age of 40. And this is quite common in the Black community. So why is it? Now, there is a very complicated answer, and there might be some genetic issues, but then there's also this thing we refer to in the literature as epigenetics, and this is about how our genetics change because of what we're exposed to. And there is a lot of thinking that some of these changes are actually rooted in structural racism, discrimination, toxic work environments, toxic home environments that Black women have faced over generations that have then resulted in this epigenetic change that causes Black women to have these more difficult experiences of the menopause, but also earlier and more likely to have premature menopause. And chronic stress due to a heavy mental load is a huge contributing factor. And that's one of the things that I want us to really think about today, because chronic stress is really an issue in the Black community. And we're going to just think about why. Now, I've titled this The Mental Load That Black Women Carry. Firstly, there's this image of the strong Black woman, and it's very much ingrained in all our minds that Black women are strong. They can manage most things. They are, but this image basically it's good because Black women have had to be resilient, but there's a negative aspect to it as well, because Black women are just expected to deal with some very, very impossible situations. And also the piling on of load, all sorts of things can push many women to the point of breaking. So this image of the strong Black woman, it's there, but what I could see is that it detracts away from the fact that we need to support each other and not try and think we can do it alone, because that, feeling of overwhelm or overload can really contribute to chronic stress. But then there's also misogyny. So this is not only faced by Black women. All women have faced prejudice driven by the historical patriarchal society, but Black women have also faced this. And some of our communities are very patriarchal, and that means that Black women are carrying a lot of the burden for society. But then there's also the weight of history. So each person has a personal story. So some women may feel like, look at what happened to my mom or my grandmother. I must go, and that story is a driving force that adds weight. It's not necessarily a bad thing, but sometimes it can be overwhelming. But then there's also civil rights and women's rights movements and the complexity that all brings, and one's own experience of that, or one's own story in all those things, and how that can create additional mental load. There's also the weight of family and cultural expectations, especially in some African communities. There's a lot of expectation that women should get married, have children, but then there's also expectation in some other cultures that women should be extremely successful and work very hard in their careers. And it's so difficult trying to balance all those weights because of the expectations. And some women might find that very, very heavy indeed. Then there's also the weight of our perceived potential. So that's something that can be internal, which is us thinking, this is what I could have been. This is what I could be if I didn't have to make impossible choices. Like, some women might think, I've had to give up or sacrifice my career, not go as far in my career so that I could raise a family, and vice versa. Or I've gone so far in my career, but the sacrifice has been being able to have a family, if that's what you want. And those who are trying to struggle both, feeling pulled apart. And there's also comparing with false equivalents, like some of the people on social media who have a whole army to help them, and you're comparing yourself with that, or even with people who live abroad. So comparing yourself to people who live in Africa or the Caribbean, where the challenges are different. So it's really important that we don't put those kind of pressures on ourselves. But then there's also the hidden traumas. And these are the things that happen to women. The weight such as infertility, miscarriage, divorce, unexpected singlehood. And this is something that is really big in the Black community at the moment, where women are struggling to find partners and then are having this anxiety that's driven by the biological clock. And then also, as women get older, there's this desexualization of the older woman and kind of making her into the mammy image of, of kind of like someone who's warm and cuddly, rather than, the woman that all the parts of the woman that she is. So all of these things can traumatize in their own way, and they can, sometimes they're not so much spoken of. They're kind of like the hidden pains of the heart. And, many women would have struggled with some of these things, in particular, miscarriage. That's something that we don't talk about enough. And in the menopause, these things can start to rear their heads because they have unprocessed traumas. And then there's also socioeconomic challenges. And all of these things drive chronic stress, which can heighten symptoms in the perimenopause and the postmenopausal period. What I often say is that the mental load a woman carries impacts her experience of the perimenopause and menopause. Okay, so what causes menopause? So the number one cause, the most common cause, is that natural hormone decline, and that's as the estrogen drops in the body as the eggs run out. So when we're born with a limited number of eggs. Once we start our periods at puberty, we start to lose on average 1 egg a month in our monthly cycle. If there's no fertilization of the egg and there's no pregnancy, then a period happens. And that will happen until the eggs start to run out. And that's that natural hormone decline. So there's other causes. So an oophorectomy is a surgery in which the ovaries are removed. And that can happen for lots of reasons. So cysts or cancers or whatever reason. And that means that the periods stop. that menopause happens immediately. It's a sudden. So usually when younger women have oophorectomies, they normally try and give them HRT to manage that transition. Also, if you have treatments like chemotherapy or radiotherapy, those treatments can also cause temporary or permanent a menopause state, and that's because they can cause the ovaries to kind of shut down. So that's why if people are going to have chemotherapy treatment or radiotherapy treatment, and they are still hoping to have a family, there's often preservation in things like egg freezing and embryo freezing and things like that. Now, primary ovarian insufficiency is something that you need to know about, because it is when a young woman suddenly stops producing, her ovaries stop working. And the most common cause of this is actually idiopathic, that we don't know. There are obviously other things that can cause it, things like infection, or things like what we've already talked about, chemotherapy, radiation, drugs, that sort of thing. But the most common cause is idiopathic. And this can be quite alarming for a young woman. Okay, so what are the signs and symptoms of perimenopause and the menopause? So perimenopause, we already talked about the fact that you might see irregular periods, but very important, and one that everyone knows about, like Auntie Mobala mentioned, the hot flushes. So actually only 20% of perimenopausal and menopausal women actually have hot flushes. What's more common is temperature dysregulation. That means we can't control our temperature as well as we used to. So people might feel inappropriately hot or inappropriately cold, and that's where the chills may come in. Also where the night sweats may come in as well. And that is its own separate issue that can interrupt sleep. But then also the menopause, the hormonal problems can actually then cause sleep disturbance as well. We can get sore, tender breasts, vaginal dryness. Now, this is a big one because this comes under this syndrome called genitourinary syndrome of the menopause. And we will talk about it later on in the talk. But this is really important because vaginal dryness can be quite distressing because it can make sex really uncomfortable. And that can become an issue for women, particularly if they're in a relationship. Women can get headaches, there can be weight gain from slowed metabolism, and also that a lot of that weight gain can happen around the abdominal area because estrogen is responsible for that small waist that women have. So as we drop in estrogen, then women may then start filling out more centrally around the abdomen. Mood changes. Now, this is really important because some women may be, I see so many women who are like, I've always been calm, and all of a sudden I'm struggling with anxiety. Doctor, I don't know what's wrong with me. It's like I'm losing my mind. I'm so anxious. Or they may say, I'm so irritable. I've always been really good at controlling my temper. I just can't manage anymore. I don't know why. And I'm like, perimenopause. And also just in line with that, we also see women having memory and cognitive challenges. So they're struggling with word finding difficulties. Some of them think, oh my God, am I getting dementia? And it's like, these are some of the very common symptoms that we see. So when women feel like they can't concentrate the way they used to, they can't process or handle as much as they used to, all of those things. And then there's also thinning hair and dry skin. All of these things are a direct result, because the estrogen receptors all over the body are direct result of estrogen being less in the receptors and causing all these symptoms. Okay, so what are the complications of menopause? So menopause is a natural process, but we have to understand that estrogen is protective for women in many ways. Okay, now estrogen protects the heart and helps us reduce our cholesterol, and it's the reason why women are less likely to have heart attacks compared to men before menopause. And so after menopause, we have an increased risk of cardiovascular disease. Estrogen also helps us protect our bone density. And so we then have increased risk of osteoporosis, which is bone density loss. That can be really devastating because it can cause fractures that can be life-altering or even life-ending. And it can also cause disability because it can lead to spinal fractures and some really, really horrible things. So osteoporosis is something to really be mindful of. Genitourinary syndrome of the menopause. So this is a condition in which there's reduced estrogen in the vagina and around the urinary system, and this can lead to what we already mentioned, vaginal dryness, but it can also lead to irritation around the urinary system. So it can lead to increased rushing to the toilet, accidents, and just all sorts of symptoms that can make it really uncomfortable down below, painful sex. So it can be really life-altering for some women. Also increased risk of sexual dysfunction, and that's where estrogen deficiency can cause a lower libido. So women might not feel like having sex in the way that they used to, and this obviously can then cause problems in relationships or even in the woman's sense of well-being, because intercourse is important for our well-being. Also, there's increased risk of dementia. This is the reason why women are more likely to have dementia in older life, because of a drop in estrogen. But the relationship is quite complicated. There's a lot of research ongoing with that. But certainly we know that there's an association between reduced estrogen and increased risk of Alzheimer's in particular. And we already talked about the changes in bleeding pattern, but it can be catastrophic for some women, especially if they already have fibroids, which is more common in the Black community, where they can have very, very heavy bleeding and in fact become anemic or even sometimes require blood transfusion. So it can be that serious. And in that situation, sometimes they may need a hysterectomy. Okay, so what are my top tips for a smooth transition? So increased physical activity. Now, I purposely have not said exercise, and that's because many women struggle for time. So it's in building physical activity into your schedule. So I often say things like just sit less, walk more. What you need to do is really try and incorporate movement into your life. And that includes doing things like classes, because they have a social function, or joining into things like golf or tennis or whatever it is that's going to get you out and about doing things, even walking the grandkids, whatever, taking them to the park, running around with them. All of that is physical activity, and it helps. It helps with your physical health. It helps with your cardiovascular risk. It helps with your mental health, but it also helps with the menopausal symptoms. Now, reducing the mental load, we talked quite a bit about mental load in the beginning. And what I would say is that it's not always easy. Some of the things that add to our mental load are systemic issues. But there are things that we can do ourselves to regulate our mental load. One of those things includes making sure that we are trying to have an appropriate work-life balance. And that also means making sure that you are having enough time for the next thing, which is self-care. And I often say that perimenopausal and menopausal women should try to have 4 hours a week of self-care. And when I say that, most women laugh in my face, but I say that because it's important. You cannot pour out of an empty tank. You have to refill the tank, because otherwise you will burn out if you keep pouring out and there's nothing left in. So how do you refill the tank? Well, there are restorative activities like spending time in nature. Nature is so restorative. Physical activity we already spoke about. But then there's also things like the arts, so theater, music, fine arts, so sometimes even just coloring, doing things like going to see a nice show or watching a nice movie, reading a good book. All of these things can help restore the soul. Then also spending time having fun. I know that it's not often that a doctor tells you to have fun, but I'm telling you, have fun. Laughter and fun are restorative to the soul. If you're not having much fun in life, your life is not going to be as enjoyable, and therefore it will feel heavier. So if you're having fun, you're releasing some of that negative mental load. It's really, really important. But then there's the other things that drain you. So I talk about the 24-hour news cycle and the social media. So if you are constantly being drawn in by notifications, so you're not being intentional about your use of social media or going to or accessing the news, what I suggest is just switch off notifications. Only go when you want to go rather than it draw you. These things are designed to create an addiction. And boy, do they drain the soul, because it's bad news. So I'm not saying don't engage with the news. I'm saying be intentional about your engagement and limit it so that it's not negatively impacting your mental health. And we already talked about self-care, so important. Think everybody is different, but sometimes it's a bath, sometimes it's a nice walk in the park, sometimes it's a massage, sometimes it's Netflix and chill with myself. Whatever it looks like for you, look after yourself. You can only put on a mask for others when you have your own mask on. So there's lifestyle changes. So making sure that you're drinking a moderate amount of alcohol, so no more than 14 units a week, because excessive alcohol can make your symptoms worse. And some women observe that wine can actually make the hot flushes worse. So just be mindful of that. And also caffeine intake, be mindful of your caffeine intake. If you're smoking, quit smoking. Sorry, if you have your mic muted, please can you mute it? Thank you. Then also, what are you eating? Making sure that you're eating a healthy diet, less processed foods, more fruits and vegetables, eating a wide range of nutritious foods. And I know some people say that healthy food can be expensive, but it doesn't have to be. There are many hacks on the internet for how you can eat healthier on a budget, but also supplements. So very important, if you're not drinking milk, and I know a lot of people are anti-dairy at the moment, or lactose intolerant, make sure that you're getting an adequate calcium intake. And there's a calcium calculator that you can check online. So if you just Google calcium calculator and you can type in your average intake of different foods, and it will tell you if you're taking enough calcium. If you're not, then you might need to take a supplement. But what everybody needs is vitamin D. So if you're not getting enough sun, you need to be taking a 1000 IU of vitamin D minimum. But also strengthening your pelvic floor muscles. And that's really important for things like genitourinary syndrome of the menopause. So you can do the pelvic floor exercises, very, very important. Now, changing your perspective. I cannot overstate this, because perspective is everything. If you think of the menopause in the negative way, you're going to experience it in a negative way because of the way you're thinking about it. But if you think about it as a new phase in life, something to be enjoyed rather than endured, then you will have a much more positive view and a much more positive experience of the perimenopause and the menopause. Now, when should you see a doctor? Now, if the symptoms that you're experiencing is impacting your quality of life, then you should see a doctor, because there's treatment available. And we're going to be talking about that shortly. And early menopause, you must see a doctor. And that's because of all the complications of menopause. So these are much worse in women who have menopause early. And that's why we recommend that women who have early menopause have HRT if there's no other contraindications. And really the main contraindication in that case would be if they have breast cancer or advanced disease in like liver disease or something like that. Now, what are the or if you want to discuss treatment options, then of course you need to see a doctor or a healthcare professional. So we're going to talk about menopause treatment options. So some of the common treatment options are hormone replacement therapy, and there's a whole section on that. Supplements and herbal treatments. Now, as doctors, we're not usually trained in supplements and herbal medicine. Some people learn about it separately. The problem with supplements and herbal medication is that they can interact with your regular medication that's prescribed by the doctor. So if you are going to use those sorts of medications, then you need to know what you're doing, or you need to seek help from someone who knows about it. So I know some women use yams and measure their doses and things like that. They really get into it. And, you know, as long as you know what you're doing, or getting advice from someone who knows what they're doing, if that's what you want to do, then that's your choice. Obviously, this is all about women's choices. So there's certainly options, and there's other kind of herbal medication that can help with symptoms. There's also vaginal estrogen, and we're going to talk about that. But for women who can't have hormones, we can also sometimes use low-dose antidepressants for the treatment of the menopausal symptoms. Now, I'm going to take a break here because I've been talking for quite a while, and just see if anyone has any questions before we carry on with the rest of the presentation. So if you have any questions, you can either raise your hand or put it in the chat. So Dr. Sharon, has anyone put any questions in the chat, or is anyone raising their hands?
Not yet, ma.
Okay. Okay, looks like someone has put a question in the chat. What about taking estrogen drugs? So we're about to talk about that. What causes frequent urination in the late 40s? Does it have anything to do with perimenopause? Yes, it can do. So that question is actually a really good question. So the question about the estrogen, the hormone replacement therapy, that's the next part, and we're about to go into that and really talk about the cancer risk and all of that conversation. So I would answer your question then. About the urinary frequency question about the late 40s, does it have anything to do with perimenopause? Most likely, yes. So there's a combination of things. So if a woman has had babies, there is a possibility that the pelvic floor is lax, because it's not something that is generally told to women after pregnancy, that they have to maintain the pelvic floor. Now, that added to with estrogen deficiency can make things very, very difficult for women in the perimenopause, where they're struggling with urinary frequency. But it's treatable with pelvic floor exercises and with vaginal estrogen. And we'll talk about the treatment of genitourinary syndrome of the menopause sometime later on in the talk. Now, when is menopause considered to be early? So premature menopause is below 40. Early menopause is under the age of 45. So we said that the average age for Black women at which Black women get menopause is 49. So early menopause is considered to be menopause below the age of 45. And that's because, again, in that category of women, we see increased risks later on in life from having gone through menopause so early. And those women, we would strongly recommend that they also consider having treatment for their perimenopause or menopause with HRT. So now we're going to come in and talk about HRT. So we'll take the next rat of questions after this. So what is HRT? It's treatment that reduces the symptoms experienced during the menopause. It's literally replacing the hormones that are lost. So we are not giving you something that you wouldn't have already had previously. So it is the most efficient method of treating all the menopausal symptoms, which include hot flushes, night sweat, sleep disruption, but also very importantly, the mood symptoms that occur within the menopause. So, and also the cognitive challenges. So the things like the brain fog, the executive function problems. So like struggling to multitask, struggling to remember, all of those things are helped by HRT. But it also helps with the genitourinary syndrome of the menopause symptoms, with the vaginal issues and the urinary issues that can occur with the menopause. Now, so the next thing that we're going to talk about is what is HRT itself. So the main biological cause of the perimenopause is estrogen deficiency, and therefore HRT replaces estrogen. The estrogen that we use in all of our HRT that we give as doctors is estradiol. It is body identical, which means it's exactly the same as our body produces. It is natural and it's derived from yams. So it comes in various forms, tablets, patches, gels, and sprays. But as we will explain, most people use the topical route, which is via the skin, because it's lower risk, and that's the patches, the gels, and the sprays. But through the skin, it goes into all of the body, and that's why we call it systemic HRT. Systemic HRT means the estrogen is going into all of the body, and that is in contrast to vaginal HRT, which is localized to just the genital and vaginal area, and that is used to treat genitourinary syndrome of the menopause. And we often use both in combination, depending on the symptoms that the woman has. Okay. Now, progesterone is prescribed as part of the HRT to counteract the effects of estrogen on the womb lining. This is because if we give estrogen alone and the woman still has her womb, the womb lining will just keep growing in response to the estrogen, and that can lead to horrible things like womb cancer. So we always, in a woman that has a womb, give estrogen with progesterone, but the progesterone is purely to protect the womb. Now, the best option for this is Mirena, and if you're a follower of Dr. Showcares, you will know that I'm a big fan of Mirena, which is the intrauterine system. It's a coil that's impregnated with progesterone. Why do I love this so much? Because not only does it provide that womb lining cover, and does it in a very good way because it's localized in the womb. Some women might have a few symptoms in their body for the first 3 to 6 months, but that usually settles. But it also works as a contraception, and in fact is a very well-used contraception. So that means that for women in the perimenopause who are still at risk of getting pregnant, it's a very good treatment, because it provides that progesterone component of the HRT, but also provides contraception, because HRT is not a contraception. And if you are perimenopausal, so that means you are still having periods, you need to keep using protection until you've not had a period for over a year if you're over 50, and if you're under 50, until you've not had a period for 2 years, because we still do see pregnancies in the perimenopause. And if that's not something that would make you happy, then you definitely want to make sure that you're protecting yourself from that. Now, There are other forms of giving that progesterone if you don't want a coil. And I understand that some women don't want that, and that's fine. So there are tablet or patch options, but these are mainly synthetic progesterones. So you have combined patches which have estrogen and progesterone in them, and that can be a neat solution. But there is a body identical progesterone called Utrogestan, and we love Utrogestan because it helps with sleep. It's a tablet, you take it at night, it's very low risk. There basically is not any significant increased risk of breast cancer for the first 5 years of using Utrogestan, and also of blood clots. So it's very low risk. So we love Utrogestan. So normally for me, it's the IUS versus Utrogestan, unless the woman really wants a combined patch. The only thing with Utrogestan is sometimes it can cause irregular bleeding, and that's because it's not as strong as some of the synthetic progesterone. So for some women, they can't really tolerate that bleeding pattern, and so we use the synthetic progesterones. Okay, now testosterone can be part of HRT. It's not routinely prescribed, but it can be added to address low sex drive. Now, you may have heard about it also helping with things like the low energy or fatigue, or some of the other symptoms that women experience in perimenopause or menopause. Well, that is still being researched, and there is some growing evidence that it might support that, but it's not currently licensed well, to be honest, it's not licensed, but it's not currently agreed by the British Menopausal Society that we should give it for that reason. The reason that the only reason where we give it is if the woman has had HRT but her libido is still low, then we can give testosterone, and it can work fantastically for some women. Okay, now we've already talked about HRT not being a contraception. So I'm not ignoring your questions. We'll take them at the end. So please keep adding them in. And Dr. Sharon, who is on the phone, on the line, is also taking a note of them. Okay, now what are the benefits of HRT? So there's the relief from menopausal or perimenopausal symptoms. There is improved bone health. Now, HRT is one of the best treatments to prevent osteoporosis and bone density loss. So very, very good for this. Improved heart health risk for the future. So again, we know there's this window of opportunity, which is when the perimenopause starts, and for 10 years after menopause, where there is that opportunity to provide HRT that can protect from that increased risk of heart disease that women get later on in life. So we call it the window of opportunity, and HRT can help with that. HRT can help with mood. We already talked about that. And then we've already talked about the relief from the genitourinary symptoms. So HRT can really help with that. Now, there's still ongoing research on this, but there is some developing research that HRT might provide protection from dementia, in particular Alzheimer's. And in fact, there is some really good research that is showing that if a woman has an ApoE mutation, that she may benefit from HRT, although it's not completely, the research is not completely clear at the moment, but there is definitely a suggestion that it might even protect from dementia. Now, this is something that people may not have recognized, that there's so many health benefits from taking HRT because everyone is so focused on the risk. So we're going to talk about the risks in a minute. Now, what are the risks of HRT? Now, the very first thing I must emphasize is that HRT's benefits often outweigh the risks for most women. And that's because things like heart disease are much bigger killers of women than breast cancer. Now, we know that that breast cancer can be more aggressive in Black women, but the survival rate from a breast cancer is still 85%. In 5 years from having a diagnosis of breast cancer, which is pretty good. If a woman has a heart attack, the chances of survival, depending on how severe it is, are not quite so good. So definitely we have to think about what is higher risk here. What are the risks versus the benefits? Now, it's really important to be informed about the risks, and we're going to be really addressing some of the common myths. Now, is there an increased risk of HRT for breast cancer? There is, and we're going to look at the actual numbers in a minute. So there is very slight increased risk for breast cancer, endometrial cancer, stroke, and ovarian cancer, but also for blood clots, but only if you're taking oral HRT. And as I've already mentioned, we very rarely give oral HRT as first line these days. Now, with cardiovascular disease, the picture is mixed because, as I said, it protects the heart from menopause and for the first 10 years, so usually up to the age about 60. But if you start HRT over 60, it can actually increase your risk of heart disease and stroke. So generally speaking, it's not a no to start HRT over 60, but we have to think about it very carefully and look at all the other risk factors, because there is a risk there with starting HRT after 10 years of being menopausal. So that's that picture where there's a window of opportunity from menopause for the first 10 years. After 10 years, starting HRT can then increase the risk of getting heart attacks. Okay, so individual risk varies, and your own background risk will be different depending on your family history, other health conditions that you may have. So HRT decisions need to be discussed with the healthcare provider, thinking about all those things. Now, let's talk about the breast cancer risk. So if we think about 1,000 women using estrogen and progesterone for over 5 years, and additional 5 to 10, so it's variable within the data, of extra cases of breast cancer may occur. So for estrogen only, around 6 additional cases may occur. So that's a very, very small risk indeed. We're talking about an extra 5 to 10 in 1,000 women. So that's even much less than 1%. So people really overstate this risk. And in fact, when we think about the risk of breast cancer, there's the increased risk, the very small increased risk of getting breast cancer, but there is no evidence that increases the risk of dying from breast cancer. Many of the breast cancers are breast cancers that wouldn't kill the woman. So that's why this myth about HRT causing breast cancer is really not true when you examine the data. Now, let's talk about blood clots, because that's another one. Now, transdermal, which I was talking about, giving estrogen through the skin, are thought to have no additional risk for blood clots. And in fact, women who have conditions that predispose them to blood clots are allowed by hematologists to have HRT. That's how low risk is considered. Now, there is a risk with taking HRT orally, but that's not something that's done that commonly. And with that risk is 20 to 30 extra cases in 1,000. So we're still talking about quite small risks here. Now, with endometrial cancer, so I've explained that there should really be no situation in which a woman is using estrogen-only HRT if she has a womb. But we know that estrogen can increase the risk of endometrial cancer. So we only prescribe combined HRT with a woman with a uterus. That is, we would never give a woman estrogen only HRT when we know that she has a uterus. And in fact, if the woman has endometriosis and has womb lining tissue outside of the uterus, we would still, even if her womb has been removed, but she has endometriosis, we would still give progesterone to counteract that effect. Okay, now we already talked about this, the relationship between HRT and heart disease. So I've explained about the window of opportunity. And I explained that when older women use HRT, there might be 5 to 10 additional cases of heart disease if it's initiated after the window of opportunity. And as I said, that's usually over the age of 60. So 10 years after the average age of menopause. So HRT can be associated with 5 additional cases in 1,000 of strokes, but this again is in older women. And as I said, this risk is higher with oral HRT and lower with the transdermal. So it's again not something that it is very low risks indeed. And finally, ovarian cancer, so 1 to 3 in 1,000. So these are very, very small risks. So it's, you know, I cannot overstate that the benefits of HRT for most women far outweigh the risks. And it's only for women who have had breast cancer or have a genetic mutation that predisposes them to breast cancer that they may have to have a longer conversation about some of these cancer risks. Now, it is crucial to remember that individual risks may vary, and so each person needs to discuss with the healthcare professional about their own risks. Now, care for the menopausal woman's general health. Now, this is really important to me because it's the bread and butter of the work that I do. Now, when we look at menopause care, it doesn't exist in a vacuum. I'm thinking about the general well-being of the entirety of the woman. So I'm thinking about her cardiovascular health. So we're thinking about other risk factors, her blood pressure, HbA1c, which is a test for diabetes, her cholesterol levels. Also, we talked about the diet and physical activity, smoking, alcohol, all of those things. Bone health. So what we would do in clinic is we would assess something called the FRAX score. If the FRAX score is high, we would then recommend somebody have the client have a DEXA scan, which is a bone density assessment scan. And if the bone density is less, then we would consider treatment because, and generally speaking, this applies to all women. But when we see women who are postmenopausal, who haven't had HRT, all of this becomes far more important because of their higher risks. So that's why we're so, you know, when I see postmenopausal women, I'm all about their general health and making sure that we're mitigating all the factors of the complications of menopause. So making sure that they have an adequate calcium and vitamin D intake, and we already talked about that. Now, joint health, I cannot overstate the importance of strength exercises, and that's doing things like weights. It doesn't have to be anything really heavy, just resistance exercises to build that strength in the joints, but also flexibility exercises and balance exercises. So we talk about things like Pilates, yoga, Tai Chi, all of those things, because balance and flexibility reduces as we get older. So if you don't work on it, it can become more of an issue. So it's really, really important. But also for brain health, you know, eat omega-3 rich foods, prioritize sleep. Sleep is not something you can play with in the postmenopausal period, because if you don't sleep, things are going to be much more difficult. And staying active and alert, so important. Keep that brain active. Now, for mental health. Now, as I mentioned, during the perimenopause, menopause and postmenopausal periods, some things that might be hidden traumas may be unversed, or things that haven't been processed. So it could be bereavements or losses or whatever. And it may then become useful to process some of that emotional pain through therapy. But sometimes also people struggle with just facing the symptoms of the menopause or perimenopause or postmenopause, and sometimes it might be really useful to speak to someone in therapy, but also we can form support groups and support each other. That's what we're, support from friends and family can be really helpful as well. Now, breast health, really important, because breast cancer risk goes up as we get older, and that's for everybody. So this has nothing to do with HRT. It's just what happens biologically, that there's increased risk of breast cancer as we get older. So it's really important to do monthly self-exams and regular mammograms. Now, the frequency of mammograms varies across different countries. Just do your mammograms as and when you're called. Now, the other thing is to make sure that you're doing your regular cervical screenings, because even though it's less likely the older you are, it's still important to get checked when you're called for your cervical screen. Very important. Now, we're going to talk about care for genitourinary health. So this is for the genitourinary syndrome of the menopause. Now, I cannot overstate the impact of localized estrogen. And unlike systemic HRT, localized HRT has very little risk and can be used for life. And many women in their 80s, 90s are still on vaginal estrogen. And that's because many of the other symptoms of HRT, like all the sort of night sweats, hot flashes, many of them get better with time. But the genitourinary syndrome of the menopause symptoms, that's the vaginal dryness, the urinary symptoms, those don't get better without treatment. In fact, they get worse. So really important to get treatment sooner rather than later with localized estrogen. Now, for the very few women who cannot have localized estrogen, then, you know, there are other options like, I mean, to be honest, all women can use the vaginal moisturizers. So good brands include Yes, and Replens. And when you're having intercourse, please do yourself a favor and use lubricants, because it really does help increase pleasure, but also reduces the risk of damage to those under estrogenized tissues, to the tissues of the vagina when during that menopausal season, during the menopause or postmenopausal time. So really important to use lubricants. Now, the urinary symptoms, the localized estrogen can help. But using things like pelvic floor exercises can really help. But if the symptoms are, because the other thing that can happen is prolapse can happen as well, particularly if you've carried babies, you can have vaginal prolapse. So you might need surgery, or you might need treatment to keep the prolapse up, so that can then reduce the chances of urinary incontinence or the uncomfortable dragging sensation. There are other medications that can be used to help with incontinence, depending on what the type is, whether it be stress or urge incontinence. But generally speaking, for the incontinence and urinary symptoms associated with the genitourinary syndrome of the menopause, localized estrogen and pelvic floor exercises really do help. Now, it's really important to not use soap. Just don't do it. Do not use soap or shower gel or anything that foams to wash your vagina or genital area. You need to be using an emollient, which is kind of like a moisturizing cream, and there are lots of different ones. I've put Dermal 500 on there as an example, and the reason why I like this one is because it comes with a pump, so you can easily just put it in the shower and use it as a pump. But there's many, so you can use any emollient. So you can go and ask a pharmacist for an emollient moisturizer, because washing with soap just dries out the skin, and even just using water alone can also dry out the skin, particularly if you live in parts of the world with harsh hard water. So now it's really important to also just make sure that you are keeping up with your yearly or 2-yearly health checks to ensure your general and genitourinary well-being within the post-menopausal period. So really, we're now coming to a close. So essential support is crucial for effectively managing menopause and perimenopausal symptoms. Seeking help enhances your current quality of life by addressing health changes, and it sets the stage for a healthier, more fulfilling future. So if you seek professional guidance, it can give you personalized insights into your own situation and treatment options. But you can also get support from each other so that we can be empowered to have an incredible post-menopausal and post-menopausal experience. So I've come to the end of my talk. It's now time to take more questions. So I'm just going to have a look in the chat, but if you want to ask your question, you could also raise your hand. So let's have a look. Few more messages. Okay, so I'm actually struggling to see all the questions, that the previous questions that were asked.
I could read them out.
Okay, yeah, Dr. Sharon, please read them out for me.
Okay, so the symptoms listed on the slide are typical of gynecological issues women have. How easy is it to isolate causes?
Okay, so some of the symptoms can be associated with some other gynecological issues, like, for example, heavy bleeding or changes in your bleeding pattern can be caused by lots of different things. But there are some things that are unique to the perimenopausal, menopausal situation, such as what we talked about, the temperature dysregulation, the mood symptoms, the drier skin, the drier hair. I mean, a lot of these things can be caused by a lot of things. And there's something we who work in menopause say is that there's very few symptoms that cannot be caused by perimenopause and the menopause. And in much the same way, sometimes it can be quite difficult. But I think you have to look at things on a whole, and think about, what am I experiencing? What's happening with my periods? What how many of these symptoms am I getting? Am I getting a cluster of the symptoms? And it can be helpful to talk to a healthcare professional. Now, there are blood tests that can be done, but usually in the perimenopausal time, they're not that useful because I said the hormones go up and down. The blood test can look like your normal, what you would have looked like during your normal cyclical period time. So sometimes the blood tests during perimenopause don't give that much of a clear answer. So it's a clinical diagnosis based on the symptoms that a woman has and her age and her experience, and that's something that is diagnosed with the combination of the woman's and the clinician, the or doctor or nurse or healthcare professional. But can it be tricky? Sometimes it can be. And sometimes we have to unpack other things as well. So generally speaking, when women come to see me in my menopause clinic, I will also check other things like thyroid function, iron levels, B12, folate, all these other things that when they're deficient, I'll check their full blood count. All these other things that when they're deficient, it can give some of the symptoms that women can experience in the perimenopause or menopausal period. I mean, menopause is much easier because women would have stopped their periods for a year. So, and usually the blood tests with menopause are clear that a woman has had menopause. So it's much easier to diagnose. So it's perimenopause that can be a little bit tricky. So with the genitourinary syndrome of the menopause, the vaginal dryness is usually and there's a way the skin of the vagina looks. So if a doctor or nurse or healthcare professional examines, they can really be able to tell that, oh, this looks like the vaginal dryness associated with estrogen deficiency. I hope that answers your question. Sharon, the next question.
Okay. Busayo Akindoyin says, very stimulating lecture. I see you're a member of the British Menopause Society, wondering if there's a Nigerian Menopause Society. She also asks, what are your recommendations for locally available methods of dealing with postmenopausal symptoms?
So yes, I'm a member of the British Menopause Society. Have to be honest, I don't know if there is a Nigerian menopausal society, but if there isn't, we need to rectify that. I will do some research to find out about whether there is or what about the state of that. When we're talking about locally available treatment, I'm not exactly sure what that means. But if it means like natural herbal treatments. So as I've mentioned, I will always defer to local knowledge. There is a lot that in Western medicine we don't know, and that there's things that traditional practitioners might have knowledge in, but we stick to scientific data, and that's why we recommend treatments that we know what we're giving you, we know what's in it, we know what the risks are, what the benefits are. And so that's why we would recommend treatments that are body identical, that are natural, to treat HRT and to treat perimenopausal and menopausal symptoms, and that's what HRT is. Now, do some women use yams, red clover, black cohosh? Now, there's loads of different herbal things that women use, and like I said, I'm not here to judge what people's choices are. The only challenge is it can be quite difficult to clarify exactly what's in preparations, and sometimes people might say something is something but it's not, so that can be quite difficult. So as a Western medical practitioner, I don't prescribe herbal medications, but that's not something that I'm not willing to learn more about.
Okay.
I hope that answers that question.
Okay, so next question. How is a woman able to have a baby at age 60 when menopause is expected to have set in?
So if a woman has no more eggs, now, are there some women who have very late, very delayed menopause? Yes. And this can be actually quite notable in some Asian communities. I've seen women of 59, 60 who are still having periods in that community. So is it possible? Yes, but if a woman has had all her eggs used up, and she is menopausal, then she's not going to be able to conceive naturally because there are no more eggs left. But what can happen is she can have a donor egg. If her womb is healthy, she may still be able to carry a pregnancy made from a donor egg that is implanted in her womb. So that is a possibility. Or if she had frozen eggs from when she was ovulating, then she might be able to use her previously frozen eggs or embryos to carry in her womb at age 60 with the right IVF support. Was there what was the next question?
Okay, so Folashade asks, what is maximum number of years for HRT, or is it a lifelong treatment?
No. So very, very, very good question, Folashade. That was a very good question. So HRT is not usually a lifelong treatment. We normally give treatment for for as long as a woman needs. There's not really a prescriptive time. And there's also not a prescriptive time to stop. So probably on average, most women use it for 5 to 7 years and then stop. But that's not something, the BMS does not recommend an age for stopping. Now, do we start having conversations with women who are on HRT at the age of 60 to think about the risks versus the benefits? We do. I certainly will, talk about, we're 60 now, the higher risks of, but as I said, the risks are still quite low. It's just that the background risk of the woman for things like breast cancer and ovarian cancer and endometrial cancer is rising as she gets older. Well, not endometrial cancer, but breast cancer and ovarian cancer. So in that regard, we would be having a conversation with the women like, at 60, you might think about wanting to stop. But some women are so, they love their HRT. They're like, Dr. Johnson, you're not taking my HRT from me. And, they're my boss, right? The patient is because this is patient-centered care. So as long as the patient understands the risks and the benefits and understands what the potential risks are, if she chooses to want to continue HRT, then she can. And certainly there are women who are well into their 70s, 80s that are still on HRT. I wouldn't say it's common practice. Generally speaking, most women come off HRT, as I said, after 5 to 7 years of being on it. Because as I say, a lot of the time, the body adapts to the perimenopausal symptoms. But it's that genitourinary syndrome of the menopause that doesn't get better. And many women are on vaginal HRT for life. I hope that answers your question.
So, Ozioma asks also, are there any other ways to induce menopause apart from total hysterectomy? I'm in my mid to late 40s, but I can hardly wait for it to come since my cycle is relatively short, 24 days, and it comes with severe pains for 2 to 3 weeks.
So there's not really anything that, well, apart from removing the ovaries, that can hasten HRT. But if you're having painful periods, I would really recommend that you see a doctor, because there's a whole host of things that could be causing that. And you probably need to be investigated with a scan, swabs, and maybe even a hysteroscopy, which is like a camera to look in the womb to have a look to see what's going on. So I would recommend that you see a doctor who knows about women's health issues, because you shouldn't be suffering with painful periods. There's help for that. And in fact, one of the things that we come, if there's no untoward causes, one of the things that we commonly do is actually put in a Mirena. I talked about that earlier, and to help with this, because with people who are on the Mirena coil, many periods get lighter, and in fact many women actually stop having bleeds on the Mirena. So that's something that could work for you, so something to consider.
So the last question is from Joy, and Joy says, thanks so much for this awesome knowledge. Please, when will this frequency in urination stop?
Okay, so it depends on what the cause of the frequency urination is. So you would need to see a healthcare professional to be assessed, but depending on your age, if you have carried babies, how many babies you've carried, and whether you've got a prolapse or not, would determine the treatments that would be recommended. So if you are perimenopausal, then you might need vaginal HRT. Like I said, don't wash with soap, wash with an emollient. You might need, if you have a prolapse, you might need treatment for that with pelvic floor exercises. And if that doesn't, or seeing a women's health physio, and if that doesn't work, then you might need surgery to help with that. But then there are also medications that can be prescribed for incontinence or urge. So I think you need to see a healthcare professional that knows about women's health, that knows about urinary symptoms, that can really help you in your specific situation. But this is not something that gets better on its own. So I would really advise that you see someone, because it might even get worse if you don't get help.
Okay, so we had 2 questions come in as you were speaking. One is from Fola Shade, and she asks, is it better to start HRT perimenopausal or postmenopausal?
I would say that you should start as soon as the symptoms are impacting your day-to-day well-being, because as I said, there are many benefits of HRT. So generally speaking, many women start perimenopausally here in the UK. And that works quite well for them because, you know, we're not in the days of our foremothers. You know, many of them, by the time they were in their late 40s, early 50s, they were already done with child rearing. They weren't working anymore. But us, many of us in our generation still have young children, or we are still working and so still expected to be at a very high operational level. And therefore, if the perimenopausal symptoms are impacting your ability to really work at or function or live at your expected level of yourself, then you need to get treatment. And so that's why I would say that it's a personal decision depending on the impact on your life, but certainly really consider getting treatment when the symptoms, if the symptoms are bothersome, and whether that's in the perimenopause or menopause. But remember that for some of those protective benefits, there is that window. And to be honest with you, we don't love to start HRT after the age of 60. Not that we don't do it, we do, depending on the situation. Everything is a case-by-case situation. But, you know, generally speaking, we prefer to start HRT within the perimenopause or in the first 5 to 10 years of menopause.
So from Olayemi, she asks, does alcohol intake have any effect on menopause?
So alcohol intake can impact the symptoms of perimenopause and menopause, and in particular they can make hot flushes or temperature dysregulation worse, and this also goes for caffeine, but it's alcohol in itself is not going to affect you the timing of your perimenopause, if that was your question. But yes, certainly it can make symptoms worse if you're excessively drinking.
Okay, those are all the questions in the chat box. Just have a lot of comments saying thank you, Dr. Sho, for this educative lecture, from Hajara, Aurelua, Adishina, amongst many others.
Thank you everybody for coming. The attendance has been amazing. I hope this was helpful. So just so you know, our menopause clinics are coming. So this is very exciting news. We're really excited. Our menopause clinics are going to be coming to Lagos and to the UK. So we're going to have a clinic online in London and in St. Albans from January 2024. So if you're interested, please register on the Dr. Showcare's website, the drshowcares.com, to stay informed and be among the first to know when the clinics are opening. But, you know, if you have any just general questions, you can send them to us. We can't answer personal questions about your health because we're not licensed to do so until our clinic is running, and then we can obviously address things in the clinic. But we can answer general questions that you may have, just as you've been asking in this and give you some generalized hints and tips about managing your symptoms. Now, we are at the end of today. I'm so grateful for all of you. If there are any other questions, okay, someone's been talking about, I've been battling cholesterol using drugs. So again, so cholesterol can rise after during the perimenopause and the menopausal, because estrogen does help with bringing down that cholesterol. so you might find it more challenging, but you should listen to your medical professional on what medication you should use for managing your cholesterol. But there are also lifestyle things. So what are you eating? So red meat, and animal-based fats can increase your cholesterol levels. So being mindful of what you're eating, making sure that you're doing adequate physical activity, but also liaising with your doctors or for other medications, which may include statin medications. So sometimes it's a matter of what dose are you on. They may need to review that. Okay. So just any final questions? No more questions. Dr. Sharon, have you seen any more questions?
No, I haven't. Just a lot of comments thanking you.
Oh, thank you, everyone. Thank you so much. Very appreciative. So if you don't already, please follow us on Dr. Showcares. We're on Instagram, YouTube, TikTok, and all social media. So please follow us to have more updates on what we're doing and to learn more about our work. All right, thank you very much, everyone. Well, I think we're going to call it a close now. Have a wonderful night. Thank you again for joining. Bye-bye.
Thank you, ma. God bless you.
Thank you. Bye.
Thank you. God bless you all.
Thank you.
Thank you so much. God bless you.
Thank you. Thank you so much.
Bye. Thank you.
Bye-bye.
Lovely. Well done.
Thank you.
Well done.
Thank
you.
Thank you. Have a good night.
Thank you. Have a good night.
Thank you.
Thank
Nice. Well done.
Well done.
Thank
Well
you.
done.
Call it one. So I should go. I should get that. The thing is,